because I'm taking this opportunity to try to drill down into the Medicare hospice benefit and to try to convey not only what a physician needs to know in order to function within the Medicare system, the Medicare hospice system, but also to try to capture some of the nuances of the benefit so that the benefit can be used in the service of doing palliative care in any venue. Let me just say that again because I really think that's a very important lesson that I've learned personally. Since I grew up in palliative care, not from hospice, but from cancer pain. I'm unusual in the United States, and I didn't personally appreciate the scope and the depth of the Medicare hospice benefit until about 8-10 years ago. And then in the last 8 or 10 years, I have been on a constant journey to try to understand the nuances of the benefit at a leadership level in the organizations with which I've been interacting, so that the benefit can be used in the service of palliative care. I think that there is now a very broad understanding in the U.S. that hospice provides a mechanism to provide specialist level palliative care at the end of life. And that itself has been a tremendous change from the original conceptualization of the Medicare hospice benefit 25 years ago. But in the last 10 years, hospice providers, including the leadership of hospice organizations around the country and the National Hospice and Palliative Care Organization, has bought into this concept that hospice, when it's done well with high quality, provides a means to provide specialist level palliative care at the end of life, and therefore could potentially play this very important role in an effort to provide specialist level palliative care throughout the full trajectory of any life-limiting illness. Okay, does that concept make sense? Because it was an epiphany for me. Because coming from the non-hospice world, I had a lot of misunderstandings about hospice. And then when I first got into hospice and I understood the variation in the agencies in the U.S. in terms of their ability to provide quality, I didn't automatically embrace the concept that here was something that could be used well. So it took me a little time to understand that if you demand from hospice quality palliative care, it is a perfect opportunity to provide specialist level palliative care at the end of life and to use it in the service of a broader model of palliative care that might originate in hospitals or in home care agencies or anywhere else. Okay? And so I think that's a very important point, not just for providers, but also for regulators and for payers generally. Hospice has tremendous potential if it's used optimally vis-a-vis the restraints of the benefit, and also if providers who work in hospice insist on excellence, insist on quality. Now, having said that, it is not easy. It is not easy for a trainee in the professions to understand this whole separate healthcare system, because that's what hospice in the U.S. has been. It grew up 25 years ago after a 10-year genesis as an entirely separate healthcare system in the United States, separated from, siloed from mainstream medicine. And that was done purposefully. The original people who fought very hard for the creation of a hospice Medicare benefit didn't want it to be in mainstream medicine. They wanted it to be outside of mainstream medicine in order to protect the services from over-medicalization of the dying process. The original hospice philosophy, which was brought from the UK to here by some pioneers in the field, and then who then became advocates with the government to try to create this benefit, felt that the goal was to provide the opportunity for a dignified death at home. The concept was to pursue the good death in the home environment. That was the concept that was brought from the UK to the United States. And in an effort to do that, the idea was keep it out of hospitals and keep it away from doctors. And so the entire structure of the Medicare hospice benefit originated from the idea that this would be a separate healthcare system away from mainstream medicine. So the good news in that regard is that it has been a highly successful process, and it has grown rapidly from literally nothing to services that are now accessed by about 30% of patients who die each year in the United States, about 1.4 million patients and families. It's now a $12 or $14 billion benefit under Medicare. So it has grown rapidly in this siloed conceptualization. That's the good news. But the bad news is that those of us who don't work in it full time and instead are trying to use it in the service of providing specialist level palliative care at the end of life within a broader model of palliative care nationally, we have to understand this whole separate healthcare system down to its nuances in order to use it well, and also in order to stay in compliance. It's highly regulated, it's carefully audited, and the federal government has had it up to here in terms of perceived fraud and abuse. So as we're going into 2011 and beyond, compliance issues are going to become even more prominent than they have been, involving both civil law and criminal law. So it is very essential that everybody who's working in hospice has some understanding about what compliance means. So I want everybody around the table, as long as they last, to take what I've distributed here. I'm not into wasting paper, but I really felt that everybody who comes to this lecture and everybody who gets trained in this department at some point is going to have to sit down and read this large packet. And so I wanted you to have an opportunity to read it on the plane, going off to wherever you're flying to, maybe nighttime reading. But this large packet here, 73 pages, is the Medicare Conditions of Participation. These are the rules for hospice under the Medicare benefit. Right? They were recently revised a couple of years ago, first revision in 25 years, and I view this as required reading for physician fellows and nurse practitioner fellows and social work fellows and psychology postdocs and everybody else doing palliative care. This document is just for fun. This came off the NHPSCO website and just gives you a history of hospice, starting in 1965 and actually even before that in the UK. And so this hopefully will provide a historical perspective and suggest that this healthcare system has actually evolved in a very dynamic way and has changed a lot from the beginning till now. But most people in mainstream medicine don't know that because it's outside of mainstream medicine. So when you encounter somebody, a colleague or a patient or family member, misconceptions about this system are huge, despite the fact that it has grown like wildfire and actually has evolved in a way to support quality. These two documents are ones that you might just glance at and then toss if you want. One is an NHPCO tip sheet for physicians based on the new COPS. So when the conditions of participation changed for the first time, there were some specific changes that affected physicians, and that's what this is. And then this one is a document that was prepared by some consultants to do quality and compliance audits of a large hospice program. And I read this and I felt that it was the best compilation of the key elements of compliance that I've ever seen.